Hello, and welcome to Basics to Brilliance Haematology Podcast, the podcast series that will take your basic haematology knowledge up to a level needed to be an effective haematology registrar. We hope that the content we cover here will help you prepare for the dreaded Haematology FRC Path Part 1 examination. But most importantly, we hope that this series fills you with excitement for the fantastic, dynamic and highly rewarding specialty of haematology. My name is Dr. Anharad Everden, Haematology ST5 Registrar in the Southwest Deanery.
And my name's Dr. David Fazy, Haematology SHO, with aspirations to be a haemareg.
And my name is Dr. Sayed Haider Jaffrey, Haematology SHO and aspiring haematologist.
And let's get started on today's topic.
From basics
to brilliance. Hello, everybody.
Hello.
Oh, look at this. All three of us together. Whoop, whoop.
I was trying to think of a good, haematology pun, and I thought, the trilineage.
Nice.
Nice. Very nerdy.
Yeah.
That's right.
How long do you think it took? Yeah, quite a while.
A dynasty of empires.
So today we are doing von Willebrand's disease, boys. So buckle up. We've got a lot to get through. I hope you're excited. I'm sure you're alarmed by the length.
I had a little look.
Yeah. Good.
I think you're going to be doing some lifting today, I think.
Yeah.
I forgot how to read midway through.
Right, so, okay, let's just get straight in. We're going to divide this into three parts. The first part is going to be basically clinical presentation of von Willebrand's and a bit more about understanding what von Willebrand factor does first, because it's a bit more exciting than factor 8, which has been our focus in haemophilia. And then we will go on to do the subtyping of von Willebrand's disease, because you guys are very excited to find out the three types of von Willebrand's disease. And then part 2 will be tackling the lab tests, because there's a few of them. I'm not going to lie, there's a few of them, and I want us to all really well understand what the lab tests are doing, why we're doing them, how to interpret them, and I'm going to just basically fire loads of cases at you until you're on your knees begging me to stop. And then
I don't think it'll take long.
And
Pretty
then
low
we
threshold.
And then part 3 will be about how to manage von Willebrand's disease.
Right.
Okay, so let's start with a case, because that's where we always start. Okay, so I've got a 32-year-old man who is referred to haematology from A&E following a severe episode of epistaxis, which was arrested by local measures. He required transfusion of 2 units of blood. He has a history of recurrent epistaxis and had excessive bleeding following tonsillectomy aged 6. Initial investigations were as followed: hemoglobin 86, white cell count 16, platelets 480. Von Willebrand factor antigen 30 international units per deciliter, and von Willebrand factor Rickoff or activity 10 international units per deciliter. Factor 8 level 100. Any initial thoughts?
That is an incredibly diligent SHO who clerks that man to smack a von Willebrand factor.
No. They were referred to haematology.
Okay.
This isn't a clinic. This is an H&T clinic, David. Come on now.
Okay.
Anyway, it was you, wasn't it? You were the SHO.
Oh, yeah. Yes, that was me.
Very well done, David.
Thank
you for that.
What are your thoughts? Have you got any?
So I guess the thing is when we're talking about, hemostasis, this doesn't it sounds less of a clotty problem, doesn't it? Like from the get-go, an epistaxis or a mucosal bleeding says to me it might not be a coagulation problem.
Okay.
Which we've got given those tests.
Mm-hmm.
I don't know what the ranges are for von Willebrand. Well, I'm pretending not to. I've had a little look at the notes, so I've got an idea. Yeah. But I imagine those are low.
Mm-hmm. Okay. Yeah. Good. Anything to add, Haider?
We did the hemophilia C, and we saw how prevalent it was as well, and they had a lot of mucocutaneous bleeding.
Mm-hmm.
But
okay, so you're thinking about hemophilia C. That's true. I mean, to be fair, we haven't. Yeah. I haven't given you a PT or an APTT, but when a question gives you von Willebrand, scream. is
I
usually
feel
a
like
clue,
It
but
is
not always.
leading.
But not always. And actually, doing a haemophilia screen, a von Willebrand screen, is a really important part of a workup for a haemophilia A. That's actually really important. You should, if you're thinking about haemophilia, you should be thinking about ruling out von Willebrand disease, and we'll go into why that is later on. Okay, good. And so then we've got some further tests, which are probably not going to mean anything to you, so we will come back to them. But a collagen binding study was normal. The Ripper was reduced, and von Willebrand factor multimers were normal. So what is the diagnosis? Okay, we'll leave it there. We'll leave it there. That's enough. That's enough. Before I lose you entirely, and then I don't get you back.
it feels like the exact reason that other specialties think hematology is so inaccessible. Like
No.
Ripper, what
Yeah,
collagen? But
yeah, okay.
I just said, why is this man bleeding?
Okay, but I guess the main thing that you've picked out is that it sounds like more of a primary hemostatic disorder with a mucocutaneous type bleeding pattern from that clinical case, and we will come back to that case again when we have covered the lab tests and the subtypes of von Willebrands, and it will all make perfect sense. So let's start with talking about von Willebrand's disease. Obviously, so far, our main focus has been all about haemophilia, A, B, C. So in comparison, do we know how common von Willebrand's disease is compared to haemophilia?
Very common.
Yeah.
It is
It's the
most common.
Yeah.
Inherited bleeding disorder. Yeah.
Yeah, exactly. So von Willebrand's disease is the most common inherited bleeding disorder. And can you tell me anything about, with haemophilia, it was quite simple. The level of factor VIII corresponded to the amount of bleeding you would expect to see and the clinical phenotype. And the severity of haemophilia A is very much determined by the factor VIII levels. Is this the case with von Willebrand's factor? Leading question.
No.
Yes.
I think what von Willebrand's disease is not one disease, is it? It's a collection of disorders affecting the quantity or function of von Willebrand's.
Yeah, exactly.
Not
Exactly.
you can't just measure something and go, you've got severe, mild, moderate,
Yeah, exactly. It's a more frustrating and messy condition, I would say, because the level of von Willebrand factor does not correspond as well to the bleeding phenotype as it does with something like haemophilia. So actually 1% of the population have low von Willebrand factor levels, but only 0.1% of patients that have low von Willebrand factor have bleeding associated with this. So it's very much a diagnosis where you need a bleeding history and you need lab evidence of low von Willebrand factor level or activity to be able to make the diagnosis. And there's a huge amount of variation on what is considered normal von Willebrand factor levels in the normal population. So you can have lots of people who don't have any bleeding, don't consider themselves having a bleeding disorder. We probably never even see them in clinic, but their levels of von Willebrand may be lower than our reference range. And that's what we.
Did I hear that O blood types tend to have a lower von Willebrand's?
Yeah, exactly. Yeah, that is correct. And basically, blood group O, they have about 25% lower levels of von Willebrand factor than the other blood groups, and it's due to the level of glycosylation. So in blood group O anyway, you have less glycosylation. I mean, that's why you get the O antigen and you don't get the modified A or B on your red cells. And glycosylation basically protects proteins in the blood from being broken down, and so you have less glycosylation in group O, and therefore your half-life, I guess, of your von Willebrand factor is lower, or it's less protected from being broken down. And so on average, you have 25% lower levels of von Willebrand factor anyway, and that's normal. And yet we don't have, a load of blood group O people bleeding more. It's just not, it's not clinically significant. So yeah, that's true, David. Yeah. Okay, great. So it's also very polygenic as a condition. So, in haemophilia, we talked about the X chromosome and you having this, mutation that is in factor VIII gene that commonly occurs. In von Willebrand's disease, you can have both autosomal recessive and autosomal dominant inheritance. And even within autosomal dominant inheritance, you can have like quite variable penetrance. So even if you have a positive family history, it doesn't necessarily mean that the baby is going to be born with von Willebrand's disease. Good. And I think some of it boils down to the fact that von Willebrand's factor has more roles than factor VIII as well. Factor VIII very much just has the role of, the clotting cascade and its role within that in making the 10As complex with 9 and 10. As von Willebrand factor, we'll talk about in a bit, does a lot more than that. And I think that also gives this quite kind of variable picture. Okay, I thought that was just nice to just kind of compare and contrast because haemophilia is like our safe place at the moment.
your safe place still feels like a danger zone to me. But yes, I think, I can say the right words with haemophilia.
Okay, fine. So, how does von Willebrand's disease present then?
With kind of mucocutaneous bleeding through procedures like in this case. So,
okay.
Picked up, if you are symptomatic, I'm guessing you pick it up sooner in life, as in it presents sooner in life.
Okay. Yeah.
Does that make sense?
Yeah, so it's mucocutaneous bleeding. So it's gums, teeth, nosebleeds, epistaxis, bruising. Menorrhagia is a big one, okay? And remember that this is autosomal dominant a lot of the time, but either way, even if it's autosomal recessive with the rarer subtypes, it's not X-linked like haemophilia was. So this is a disease, if you've got a woman with a bleeding history, kind of von Willebrand's is sort of something that moves to the top of your differential compared to things like haemophilia A. So if you've got a woman with a bleeding thing, you tend to think straight away, could this be von Willebrand's? If you've got a boy that's got a bleeding problem, you kind of tend to think about haemophilia A. Also, obviously, think about the clinical presentation and the pattern of bleeding. But yes, it's largely a mucocutaneous bleeding pattern, and we'll talk about why that is in a minute when we talk about the function of von Willebrand's factor. There is a subtype of haemophilia of von Willebrand's disease, which does present more like haemophilia, so more of a secondary hemostatic picture with deep muscle bleeds and joints. But that's a rare subtype, which we'll go into later. Generally speaking, it's mucocutaneous, and basically it's quite hard to pick up as a result because mucocutaneous bleeding is often, I think, is like an exaggeration of normal bleeding. So, particularly with women, having a period is normal every month. And so that is normal bleeding. It's not and so then it's about the challenges working out how, is that abnormal compared to what should be normal? And often women, if they've got a family history of von Willebrand's disease, that might just be normal for their family. And, they'll ask their mum, is it normal for me to have this really heavy period? And they'll be like, yeah, that's how mine have been as well. And so sometimes it can be difficult for the patient to even recognize that they've got an abnormal bleeding history because it's just an exaggeration of normal bleeding, if that makes sense. So, I mean, it's worth, particularly because of menorrhagia being a big kind of presenting complaint, to just make sure that we are confident with picking that up. So heavy menstrual bleeding is defined as 80 mils of blood loss a cycle, which is completely obsolete. But the questions to ask when you're doing a history are things like, do you need to double up with your pad or tampon? Do you need to change pad or tampon in the middle of the night? Are you using more than 4 or 6 a day? Flooding and passing clots. Bleeding through, if a woman's saying she's having to put a towel down at night when she's on her period, then that's abnormal. And so and there's some estimate of an overnight pad would contain 10 to 15 mils of blood, so you can kind of estimate that based on the 80 mils in a cycle. So that's something to think about. Do you know of any tools that you would use to pick up abnormal mucocutaneous bleeding?
No, I take it there is a scale somewhere which we don't know about.
So when we did our very original podcast on the basics of the coag screen and stuff, we talked about using the ISTH BAT or the bleeding assessment tool.
Oh yeah,
yes. I was there for that podcast.
Exactly, David. I can't believe you don't remember a year ago. But basically,
I'll never make a heme reg.
Yes, you will. But yeah, basically, it was never designed, I don't think, to pick up abnormal bleeding. It was designed actually to kind of standardize reporting of bleeding phenotype in trials. But as with a lot of these things, we then adopted it to provide kind of help with the diagnostic process. and you basically you go through their hemostatic challenges in life, so labor, teeth extraction, surgery, etc. And then you basically score them. And you can find it on like the Practical Hemostasis website, or I think it's on MD Calc as well. And basically, a score of greater than or equal to 4 is significant for men, greater than or equal to 6 for women, and greater than or equal to 3 for children. It's not the best score in the world, and and as I said, it wasn't designed to pick up abnormal bleeding. It's particularly not great because each domain can get saturated quite easily. So, for example, you could have like 5 postpartum hemorrhages, each needing transfusion, and you'll still only score like maximum points in that one domain. Even though obviously that feels like more significant clinically. But it is still useful. It's useful for me, I find, in clinic to make sure I don't forget one of the aspects of the bleeding history. And in terms of odds ratio, one of the most predictive things is how long you bleed after a superficial cut. So do you know how long is considered like significant in terms of bleeding from a superficial cut?
2 minutes, I guess.
Longer than that, actually. 10 minutes is significant.
Okay.
And that's been shown to be the most predictive of you having a bleeding disorder out of all the different kind of domains of the ISTH BAT. So bleeding history basically is really important. And with von Willebrand's disease, you get post-surgical bleeding, traumatic bleeding, and then mucocutaneous bleeding, in particular menorrhagia. Do you know there's another type of bleeding that they particularly get, which I've seen a few times in patients with von Willebrand's disease? Do you know what it is?
Is it
It's a type of
anything to do with the
mucocutaneous.
eyes?
No.
Oh.
So it's GI tract bleeding. So they get a particularly high rate of GI tract bleeding, and it's usually because they have higher rates of angiodysplasia. And we used to think that this was just a coincidence and that these patients just have angiodysplasia picked up more because they've got this mucocutaneous bleeding pattern. But actually, we think that von Willebrand's probably has a role in the formation of the vasculature within our gut, and that something is wrong with their von Willebrand's factor, which makes them get angiodysplasia because they have more angiodysplasia than that of the normal population. And so they get a combination of angiodysplasia and then this mucocutaneous bleeding disorder anyway. And so GI bleeding is the main cause of hospitalization in patients with von Willebrand's disease. And certainly I've got a patient that comes to day unit with recurrent GI bleeds, chronic iron deficiency anemia, recurrent scopes. They can't do very much for angiodysplasia, so it becomes a bit of a to and fro between gastro and hematology, and it can be quite difficult for the patient, kind of stuck in the middle. Because often there's only so much you can, well, we'll talk about management another time, but angiodysplasia and GI bleeding in particular can be a presenting complaint of von Willebrand's. Good.
It kind of sounds like your typical patient who's on clopidogrel. They always present with, that kind of epistaxis or oozy bleeding, GI kind of things. They come in with a low HB. I think I'll use that as my rule of thumb. If it sounds like cloppy and they're not on it, then maybe I'll think von Willebrand's. Yeah.
Well, exactly. And that is the case because clopidogrel and von Willebrand's are both an issue with primary hemostasis and that formation of the initial hemostatic plug. Brilliant. And that's a nice segue on to talking about the different roles of von Willebrand's factor. Okay, so can you tell me anything about von Willebrand factor as a protein? Any facts at all?
So I guess you mentioned it's kind of got 2 roles, one in primary hemostasis, so sort of platelet adhesion, and then it sort of has a role in secondary hemostasis, which is sort of, factor 8 stabilization and prolonging their half-life. So it's kind of got a couple roles in the whole production of the platelet plug and then its longevity. Yes,
that's true. Just talking more about the structure of it to start off with, can you tell me anything about the structure of von Willebrand's? And then we'll talk about how that relates to its role.
It's large.
It's large, did you say?
Well done, Anastasia.
Yes. It's enormous. It's enormous, actually. It's a very cool protein. I don't know if maybe listeners can Google it at home to see the structure of von Willebrand's, because it is actually a very cool structure. It's the largest soluble globular protein that exists in human circulation. Okay, and it's encoded for on chromosome 12. And it basically can exist globular as a curled up ball, and that's predominantly how it carries factor 8. But then, do you know what can happen with shear stress?
It unfolds.
Yes, it unfolds. It's amazing. It like if you Google images of it, it literally unfolds like a slinky or like a spring, like a giant spring. And that is basically to allow it to tether platelets to collagen. So when you have your primary hemostasis and you have damage to the vasculature and you get exposure of the subendothelial collagen, the first thing that needs to happen is these fast flowing platelets that are going by this damaged blood vessel, they need to be able to stop and get anchored on. But I imagine it's like quite hard for a receptor on a platelet to interact with like collagen. Because it's going past really quickly, and you know the blood is flowing past.
And probably in the middle.
No reason for it to stop. Exactly. Yeah, and in the middle. Yeah, precisely, David. So what von Willebrand's does, which is just so cool, is it kind of acts like a lasso. So it sticks at one end to collagen, and then it can basically like unfurl with the shear stress within that blood vessel wall and act like a spring to kind of grab the platelet. So that even when the platelet's going past at quite high speed, you can almost imagine it going like doing and then like bringing it back. And that's kind of like how I imagine the role of like von Willebrand's. And the fact that it goes from this globular structure and then can unfold, and it's through these like disulfide bridges. It has like literal hinges like a spring. So, and that's why it's such a crucial first step in primary hemostasis, because it's that initial anchor that activates the platelet. And then once the platelet's pulled into the proximity of the collagen and the blood vessel wall, then other platelets can stick to it. And then it all gets quite easy after that. You know, they all get excited, they degranulate, they get their mates to come over, and it's all fine. But it's that initial like
their flippies and their floppies and whatever they're called.
Exactly, or their granules that degranulate. Yeah. But like the initial lassoing and springing and pulling it back to the collagen where the blood vessel's been damaged is done by von Willebrand's factor, and it's directly related to that amazing structure of it being a globular ball that then unfurls with shear stress, and that's integral in its role and in its structure. So that's something I wanted to highlight to you guys, because I think it helps you understand it. And do you know where von Willebrand factor is made?
Vascular endothelial cells.
Yeah, good, very good. So it's made in the vascular endothelial cells and then released into the blood. And this is happening all of the time. So this is like I always say this word wrong, constitutively. Is that how you say that word? As in like when it's
I mean, if you want to make up words or something.
No, I'm not making up. You know, constitutively. I don't know how you say it. But basically it's being released into the blood all the time. Don't laugh at me, Hader. And it's being released as pro von Willebrand factor dimers. Okay, so it's being released into like in blocks of two little von Willebrand factor molecules as dimers and as small multimers. Okay, and then some is then stored in these bodies called Weibel. I'm probably pronouncing
it. Yeah.
Yeah, Weibel Palade bodies. Yeah. I'm just going to call them WP bodies from now on to save myself the embarrassment. Wait. And that is a source of extra von Willebrand's disease when we need it. Okay, and basically the dimers can then undergo multimerization with these like disulfide bridges to make this then spring. So it's like components that are built together to make a spring, which is then your high molecular weight multimers via these disulfide bridges, okay? So it's secreted as dimers predominantly, and then the dimers in the blood are being built together with disulfide bridges to make it into a spring structure. Does that make sense?
Yeah, that's like very cool.
Like a concertina.
Yeah. Where are the Weibel Palade bodies? Are they in the endothelium?
They're in the endothelium, particularly like in the vascular endothelium of the lungs, for example. And they're clinically relevant because we can stimulate extra release from that vascular endothelium.
We have mentioned this before, haven't we?
Yeah. We'll come back to that in a minute, okay?
Yeah, I'll
But
hold
basically, yeah. So, but basically, the predominant source of von Willebrand factor is being released as dimers all the time into the blood from our vascular endothelial cells, okay? And then in the blood, it's undergoing disulfide links, which makes it into these high molecular weight multimers, which circulate in the blood, okay? And in the Bible Palisade bodies, those WP bodies, they're especially rich in high molecular weight multimers because we basically make the dimers, we package the dimers up by sticking them all together into like tubules and then package them into those bodies. So that releasable pool of von Willebrands is especially rich in high molecular weight multimers compared to the stuff that we constitutively just release all the time, usually as dimers and small molecular weight multimers. Does that make sense?
Yeah.
Okay, cool. And obviously, it is our high molecular weight multimers, which you can imagine are particularly important for binding collagen in that initial lassoing of the platelet to the collagen. Yep.
I guess they've got a bigger sort of surface area, so more chance of touching down.
Yeah, exactly. And I just imagine they've got more of a spring, like they can just spring out.
Yeah.
They can withstand the platelet trying to move past without letting go of it and then bringing it back in. Okay. And then what causes the release of the releasable pools? Oh, sorry, I didn't say the other place that von Willebrand factor's made. The other place it's made, do you know? So we've said vascular endothelium, in which we've got it being released from the vascular endothelium all of the time into the blood, and then we've got our releasable pool in Weibel Palisade bodies, which will be stimulated by DDAVP, which we'll come back to in a minute. But what about the other place that we make von Willebrand factor? Where else would be useful to have von Willebrand factor come out?
On the platelets?
Yeah, exactly. So megakaryocytes.
Megakaryocytes.
So the megakaryocytes is the other place that makes von Willebrand factor, and then that is then stored in granules in the platelets for release when the platelets get activated, so that they've got even more kind of ability to anchor onto the damage. Okay, brilliant. So vascular endothelial cells and megakaryocytes are our two sites of production. And then what causes are, I've already said it's DDAVP causes the release of the releasable pool of von Willebrand factor. What sort of things make DDAVP go up in the body? Apart from us giving somebody DDAVP clinically, but outside of that in normal physiological life.
I think this is a trick question. Is it pregnancy?
Pregnancy is a cause of DDAVP release, that is true. And so von Willebrand factor does go up in pregnancy.
I'll take it as one.
Isn't it basically ADH?
Yes, exactly. DDAVP is the same as antidiuretic hormone. So it's
I want to say kidneys, but I know it's not kidneys. It comes from your head somewhere.
It does work. No, it does also work on the kidneys. You're right. It's antidiuretic hormone. So when is it released? It's released when you've got a low blood volume. It's an antidiuretic hormone. So it's making you pee less. It's making you retain blood volume. So you're going to release, you can work backwards from the logic of that. So if you're making your kidneys retain more fluid, it's because your blood volume is low. And so situations like that are going to be major hemorrhage and bleeding. I mean, also dehydration and other things. But like, essentially, DDAVP will be released in big physiological stress. So in trauma, in really bad pain as well. So like some psychological things can cause, or nerve things can cause DDAVP release. We make more DDAVP at night as well, so I guess we must have maybe a bit more von Willebrand factor at night, but actually don't quote me on that, I'm making stuff up now, but basically...
So if you're going to have a big sort of traumatic experience, try and do it at night time. Got it.
Yeah, exactly.
Okay.
I think there's even, there are other things that affect your DDAVP and your von Willebrand factor, like the combined oral contraceptive pill puts it up. And so then there have been some studies looking at like cyclical levels of von Willebrand factor with the menstrual cycle, but there's nothing concrete to support any evidence of any of that. But basically, DDAVP is released when you're bleeding and you're physiologically stressed. And so that's why it's really useful that we have then this additional pool of particularly high amounts of the high molecular weight multimers that can be dumped into the blood in that situation to help the body deal with major bleeding. So how cool is that? What an amazing system. And yeah, so combined oral contraceptive puts it up as well. It's also an acute phase protein. Circadian rhythm we've said about, because basically that's because we don't want to pee at night or we would never sleep properly. which being pregnant right now is not
Yeah,
great.
Hayder and I are looking at each other
Exactly,
going,
I might need
this
a bit
is our
more of that in my
future.
life.
Yeah,
This is our
20
future.
years, maybe 10.
And then also, as you get older, for every decade of life, your von Willebrand factor level goes up by about 1 to 10%. So it might be that you have really mild von Willebrand disease early on in life and you get problems with it, and you might grow out of it if you're like borderline. So yes. What else can I ask you about? What about how it's destroyed? So we've talked about where it's made, and then we've talked about what causes its extra release, and then what about how it's destroyed? What's the
think I know this one.
half-life? What's the half-life?
Oh, I don't know that one.
Oh, sorry. Did you know the other one? Go on,
I
Hayden.
guess, like,
Sorry.
Half-life, I'll guess. Like,
Mhm.
what, 6 hours, 8 hours?
12 hours.
Okay.
12 hours.
The
So
other one,
factor 8 is 8 to 12. Von Willebrand's is slightly longer at 12 hours.
and
Yeah.
then the answer to the other one, what degrades it? Adam's T13.
Okay, good. So Adam's TS13, yes, I'm glad you mentioned that. Where have you heard the context of that enzyme before?
In whatchamacallit?
TCP.
Yes,
That's the one.
David, exactly. I mean, Adam's 13, just even the word just gives me like a Pavlov dog reaction. Because like if you're talking about anything to do with Adam's TS13, like you're basically worried about TTP, and that's just stressful. But yeah, essentially, we were talking about how the dimers get disulfide links to make them into these high molecular weight multimers. And if that was left unchecked in the blood, you would just get ongoing multimerization until you get accumulation of very high molecular weight multimers, known as ultra large high molecular weight multimers. And essentially that's what causes TTP and thrombosis, where you use up your platelets and basically everything gets clotted off. And have we done a TTP episode yet? I don't think we have we? Or did we?
No.
No.
We did ITP, not TTP.
Yeah, we will cover TTP at some point.
Well,
when
I think we should do
able to
some
get over
like
my trauma.
hematological emergencies as a
Yeah.
like a call the heme reg or something.
Yeah,
That'd be a
yeah,
nice
yeah.
episode.
We did get a comment on one of the Spotify podcasts asking for heme emergencies.
Okay,
as
cool.
well.
Awesome.
We'll definitely
We do
do
listen to you guys.
Yeah.
Yes, I am reading them.
So basically, it's a constant balance between if we just let that process go unchecked of just building the dimers into multimers, into bigger multimers, into bigger multimers, we'd end up with TTP. So then we have this enzyme called ADAM TS13, which exists in the blood and constantly cleaves von Willebrand factor to maintain that perfect balance and that perfect kind of range of different molecular weight multimers of von Willebrand. So we've got this lovely range of roles that von Willebrand factor can do. And it's a constant seesaw. So in TTP, usually what happens is you get an autoantibody against your ADAM TS13, so it doesn't work. And then that's how you get this catastrophic accumulation of von Willebrand, of ultra large high molecular weight multimers of your von Willebrand factor, and you die basically. So that's the first thing. Any other way?
Sorry, is the Adams TS13 also produced by the endothelium?
Oh, I don't know, David. I don't know where it's made.
Okay.
I presume it's made in the liver. That's what I'm going to
Yeah,
say.
so I was
You can find
I was
out
going to
let us know
say
next episode.
Okay, fine. I was just going to say,
David's
like
volunteered himself to look it up. And,
yeah, I'm on gastro at the moment.
He'll be
so I've got no
opening our
excuse.
next episode, everybody at home, with telling us where Adam TS13 is made. Thank you, David, for that.
I'll ask my good friend ChatGPT. He's very smart.
Secondly, it's cleared by the liver. Okay, so von Willebrand factor is then also cleared by the liver, like a lot of things. And so sometimes in type 1C, which is a subtype of von Willebrand's disease, where your von Willebrand factor doesn't last long enough in the blood, that can be due to liver mutations. And then also glycosylation plays a role in affecting the half-life of von Willebrand factor, as we said before with the whole blood group O thing that you said about, David. So if you glycosylate a protein, it basically makes the half-life of it longer in the blood. That's how we've made some of our extended half-life products for haemophilia A, is by glycosylation of the factor VIII. Good. Okay, so now let's move on to the functions of von Willebrand factor. We've spoken about one. What is the first major function of von Willebrand's factor?
Just a question on the glycated hemoglobin thing.
Yeah.
If you have uncontrolled diabetes,
I knew you were going to say
for
something about that.
example,
I don't know.
theoretically it should affect it, right?
Maybe it
Okay.
does. Maybe in some way that affects thrombosis rates in badly controlled diabetes. I actually don't know. I don't know the answer to that. Hader, you volunteered yourself to look that up as well.
Gosh,
Keep
she's
going
a
at this rate,
tyrant.
boys.
What have we done?
Every question.
Well, you asked me questions I don't know the answer to, so I'm sorry, but I'm going to reflect that
No,
right back to you.
that's fair. Okay, I'll find out.
We'll
You can
start.
tell you're like
I
a
need to write these
consultant
down. Right,
like
so
a consultant in training.
I am. Yes, I am.
Already.
Yeah, it's a well-known teaching technique. Actually, if you don't know the answer, just reflect it back to them, and make it their problem. So David is looking at Adam's TS13, and Hader, you're looking at diabetes.
Oh, lovely. Well, actually, on that note, I'm sorry to just digress.
Okay.
The guy who discovered von Willebrand, Eric von Willebrand, was actually really into like metabolic stuff as well.
Oh, really?
So he was one of the first people, I think, in Finland to use insulin for diabetic comas.
Interesting.
So, I mean, technically, it fits the same if you're looking at him, at least. But yeah, I digress.
Okay.
Carry on.
Well, that's a good bit of trivia. Right, back to my question. You can't avoid my question. So, functions of von Willebrand's factor. We've covered one. What is it? What's the
Binds
first?
collagen and platelets.
Exactly. So the first.
So adhesion.
Adhesion.
Yeah.
Thank you, David. So adhesion role of the platelet to the collagen. And do you know the receptor on the platelet for which it binds? One end of the von Willebrand factor.
It'd be a glycoprotein something.
Yeah. GP.
2B3A, because this is an
no
3B2A.
No. 1B.
Oh, 1B.
GP1B on platelet.
Sorry.
That's the one for collagen binding. Okay, so GP1B binds to von Willebrand factor, and then the other end of von Willebrand factor binds to the collagen. Okay, and that's your lasso, your spring, your slinky, however you want. Okay. Second role of von Willebrand factor is what?
Carries factor
Pulling
8.
platelets together.
Okay, good. Both
Platelet,
those
platelets.
are correct. So platelet to platelet interaction. That is via GP2B3A. Okay?
That's the one you wanted, Hader.
So that is where von Willebrand factor combined GP2B3A on one platelet and GP2B3A on another platelet, and therefore aggregates the platelets. Okay, it actually doesn't activate the platelets, just to warn. It just agglutinates them, so it doesn't cause them to degranulate and change shape and everything, but it does agglutinate them together, so it initiates that initial primary hemostatic plug, and then I guess once the platelets have been brought closer together to interact, then they can do other stuff which then activates each other, which we're not
It's
doing.
like a bispecific.
Yeah, it is. Yeah, it is actually. And then the third role, which I think you said, Hader, is that it carries factor 8. Very good. And that's more in its kind of globular ball type state. And that's really important for prolonging the half-life of factor 8 and carrying it around, which is why von Willebrand screen is really important in anyone you're considering a diagnosis of a mild haemophilia A, particularly if the inheritance pattern doesn't fit with an X-linked condition. You might think, is it mild haemophilia A or is it a type of von Willebrand's disease? And if you don't test for the von Willebrand screen in the lab, you're going to miss that, and you're going to misdiagnose the patient and then mismanage them. So it's really important. Okay, good. So 3 roles: platelet to collagen, platelet to platelet, and carrying factor 8. Okay? Any questions about the function that I can't answer and you can look up?
We've learned our lesson.
Yeah, no questions. Good, thank you. Well, that method of teaching worked really well. Okay, so that is basics of von Willebrand factor and how it works in normal life. Then it gets a bit tricky to know how to kind of approach the next part of this topic, but I think we should then talk about the 3 main types of von Willebrand's disease and then call it a day there today. So there are 3 types. Everything's going in 3s today. So there are 3 main types of von Willebrand's disease as per the ISTH 2006 kind of classification, which we still use. What are they? Do you know? Have you done any reading on this?
Yes.
Only just enough to get by, I think.
Because 1, 2, and 3.
Yeah.
1, 2, and 3. Okay, great. Yes.
It's a good start.
Tell me about
And,
type 1. Or tell me what you were going to say, Dave.
yeah, so this is the thing that I find quite confusing is that unlike other sort of almost linear scales like in coag, this is mild, this is moderate, is based on the type 1 was a quantitative deficiency, while I think type 2 was a qualitative defect.
Yeah.
I don't know much about it, but I do remember reading that and going, oh great, we're in for one here today.
Yeah, exactly. So, because basically, fundamentally, the reason why von Willebrand's disease is more difficult and has all these different subtypes compared to haemophilia A is you can have a problem with either its function of the von Willebrands. You can be making enough, but it's got some sort of mutation that impairs its role, which you can imagine is quite easy because, I mean, look at that exquisite structure. If anything affects that structure and it can't act like a giant spring slinky thing that unfolds with sheer stress, then you can imagine it's not going to work very well. So and it also has 3 roles, so you could get different mutations affecting the different roles, and therefore there are lots of different ways in which the function of von Willebrand factor might not be as good as it normally would be, and so therefore you've got this whole kind of bracket of qualitative disease where you've got enough but it's just not doing its job properly, okay? And that leads to a whole bucket of type 2 von Willebrand disease where you've got enough von Willebrand factor when you measure how much is in the blood, but it's not doing what it should do. So the quantitative one. As type 1 is where actually just its main function in primary hemostasis, particularly with tethering platelets initially, is impaired because you don't have enough. So it's not that it's not the actual protein structure itself is normal, but you're not making enough. I guess you can compare it to a thalassemia versus a hemoglobinopathy. So hemoglobinopathy or hemoglobin variant, is qualitative. This is quantitative. Does that make sense?
Yeah.
And then type 3 is basically where you've got no von Willebrand factor. Okay, so it's less than 1. So the cutoff for saying that you don't have enough von Willebrand factor level is 30. Okay. So type 1 is defined as low level antigen. It's a quantitative defect and you need less than 30 von Willebrand factor antigen on testing. Okay. And obviously, if you've got low antigen level, you're going to have low activity level as well. The two will go hand in hand because you can't have activity where you haven't got antigen. Does that make sense?
Yeah.
And then you've got a subtype of type 1 called type 1C, also known as Vicenza, which must have been discovered in some family in Italy or something. But basically, that's where you make enough von Willebrand factor, but it's cleared too quickly for whatever reason. Okay. So it's still overall, when you test, the levels are less than 30. Okay. But it's not a production problem. It's a destruction problem. For example, there's a mutation in the liver that makes you clear it more quickly. Then you've got type 3. Type 3 is near complete absence of von Willebrand factor antigen. So this is defined by very low levels of antigen, so less than 1. Okay?
Yep.
And then you've got type 2. And type 2 is more difficult. And the way you spot a type 2 von Willebrand factor is you basically have to compare a ratio of the amount of von Willebrand factor, so the antigen level, versus the activity of the von Willebrand factor, which we measure the activity on a lab test called the Rickoff, which we'll talk about next time. So for now, just the Rickoff equals activity. And specifically, the Rickoff is measuring the activity of the ability of von Willebrands to bind platelets to collagen via that GP1B receptor. So if you have antigen that's higher than the activity than you would expect, then that tells you you've got enough, but its activity isn't enough. Does that make sense?
Yeah.
So is that sort of expressed as a ratio?
It is. And it's always expressed as a ratio of activity to antigen. And I remember that as just it's alphabetical, so AC before AG.
Okay.
So activity to antigen ratio of less than 0.7 makes you think that you might have a type 2 von Willebrand disease.
Got it.
Now, within that, you can get subtypes.
Of course you do.
But the first step for you to do is to say, is this type 1? Is it type 2? Is it type 3? If the antigen is more than 1, then it's not type 3. If the antigen and activity ratio, if that activity to antigen ratio is less than 0.7, then it tells you that it's probably type 2. And the ratio trumps the antigen level.
Okay.
Okay. So if you had...
I guess there's a decent amount of variability from person to person in antigen levels anyway.
Exactly.
So
So you could have an antigen of, like, let's say 28, so less than 30. But if your activity is then significantly lower than that, such that your ratio turns out to be less than 0.7, then that would count as a type 2, because the ratio is more important than the antigen level. Does that make sense? Yeah? Okay, cool. The only exception to that is when you get antigen levels that start approaching less than 10, then the activity gets a bit dodgy. The actual lab test gets a bit dodgy. And so probably if your antigen is less than 10, that's a type 1. Because actually there's not very much von Willebrand factor there, and that's likely to be the issue, rather than the von Willebrand factor is not working properly. Does that make sense? So once it gets less than 10, we say, and annoyingly, unlike in haemophilia where you've got nice cut-offs for your severity of haemophilia based on your levels of factor 8, we don't have the same thing in von Willebrand disease. Even within type 1, there's no clear defined levels of antigen, like 30 to 20 is mild or whatever. Like, we don't do that, okay? The only real kind of consensus agreement is that when you get to antigen levels of less than 10, but obviously above 1, then that's probably considered a severe type 1. So if you've got a severe type 1 von Willebrands, your antigen levels are probably less than 10. But obviously if they're less than 1, then it's type 3.
And that's IU per DL?
IU per DL, yes.
Okay.
The whole way through, I work in IU per DL because I can think of it as a percentage, which is easier in my head than the IU per ml.
Great. Can I run it back just to make sure that...
Yeah, please.
Just to see if I understand it.
Yeah.
So type 1 is quantitative.
Mm-hmm.
It means that it's low.
Yeah.
1C... So type 1 is quantitative.
Yeah.
And it's low production.
Yeah.
1C is high destruction.
Yeah.
2 is qualitative, so it's not functioning properly because of the protein.
Exactly.
And that's why you need the activity ratio with the antigen levels.
And sometimes you might have an antigen level that's completely normal in a type 2, but then the activity is really low. So you could have like an antigen level of like 60 and you're like, oh, cool, it's not von Willebrand's. No, it's type 2 von Willebrand's because the activity is like 10.
Okay.
Yeah.
And then type 3 is very, very low, below 1.
Yeah.
And the activity is also going to be terrible anyway. Yeah.
Type 3 is like your severe haemophilia A, basically.
Okay.
Where it's less than 1.
Mm-hmm.
Yeah. Okay, good. So that is how we divide them. And then shall we go into further divisions? Oh, yes, we shall.
Fun.
I know, I don't want to lose you, but basically we then further subdivide type 2 into 4 different kinds. And then I'll stop there, and I don't want to boil your brain. And
just for pragmatism, I take it this is something that FRCP loves to test people on.
They love it. That's the main reason we need
this. This feels like if I needed to do a 30-mark question, they go
and
right.
You realise in the management part, like there's really not that much need to know. Like, it doesn't actually affect management a lot of the time, except for recognising 2B and 2N. The other subtypes, it's like, who cares if it's 2A or 2M? It doesn't actually matter. But they just they love it. They love it in exams. And so type 2 is 25% of all von Willebrand's disease. Okay, and it can be subdivided into 2A, 2M, 2B, and 2N. Okay.
Who cares about the alphabet?
I know. Well, don't worry, because I've got a way to remember what each of those letters are. 2A means you've got absent multimers, high molecular weight multimers. Okay, so A for absent, and it's absent high molecular weight multimers. So this is a functional problem of von Willebrand factor because you don't make enough high molecular weight multimers. Probably because your Adams 13 is too active, and so it's clearing away your high molecular weight multimers too quickly. So your nice normal spread of size of your multimers is skewed towards the small end. In fact, it's by definition in 2A, they're absent, the high molecular weight multimers. So this means then that you don't have those nice long lassos. So you can therefore understand that they have enough von Willebrand factor, but it's all just in a much smaller form, and because it's getting broken down in the blood, and therefore it's not as good at binding platelets to collagen. And so therefore your activity to antigen ratio is going to be less than 0.7, and you're going to have an absence of high molecular weight multimers on your lab tests. Does that make sense?
Mm-hmm.
And it's usually autosomal dominantly inherited. But with all of von Willebrand, as I said before, the autosomal dominant, most of von Willebrand disease is autosomal dominantly inherited, but with variable penetrance. So even though you've got a family history, it doesn't necessarily mean that your child's going to get it. Okay?
Question.
Yeah.
I think we might come to it in the lab section, but just in case.
Yeah.
The von Willebrand levels that they're doing, that we do, which multimers do they measure? Or do they measure the dimers? Or is it multimers? Or is it a total?
As far as I'm aware, it's just total.
Okay. All right.
Because it's an ELISA, so it must bind to a common part of the von Willebrand molecule, regardless of the size of the multimer.
Okay, and then I guess they'll do an electrophoresis or something afterwards, just to see the.
They just do an ELISA, so we'll come to it, but it's a well coated with antibody against von Willebrand factor.
Okay.
So it will be an epitope that's present on all of the different multimers of von Willebrand factor, if that makes sense. It's all built of the same thing, isn't it? It's all built of dimers. So it will be to like a dimer, basically. So that way, think of antigen level as total von Willebrand factor.
Okay.
Don't think of it in terms of size. So
2A is absent.
Yes. And then 2M for mother is M for maintained multimers. Okay. So this is where the von Willebrand factor doesn't work properly due to some other mutation. And so the activity to antigen ratio is less than 0.7, but it's got a normal amount of high molecular weight multimers when you test it. It's like, who cares? But anyway, that you just need to learn this, okay? So that's 2A and 2M. Then you've got 2B. Does anyone know anything special about 2B? Because that is one that I would want to pick up clinically.
You can't give it desmopressin.
Why not, David?
Thrombocytopenia.
Okay, good. Yeah, so 2B, I remember it as bonkers for platelets. Okay? So it's a gain of function mutation in your von Willebrand factor, such that your von Willebrand factor has gained too much affinity for the platelet receptor GP1B. Okay, so your von Willebrand factor binds to your platelets more than it should, and it uses up your platelets. It consumes them, and they get removed. So you get a thrombocytopenia often in 2B, but it also means if you were to use desmopressin, DDAVP, to stimulate more release of that patient's endogenous von Willebrand factor, because it wants to stick to the platelets so much, more von Willebrand factor will stick to the platelets, they'll get used up and cleared, and you'll worsen the thrombocytopenia.
So you're almost producing a TTP.
Yeah. Well, it's not TTP because it's not about the size of the, and they don't get clots, they get bleeding. It's more of a, I'm trying to think of ways, it's more like in DIC when you use all your clotting factors and then you don't have any left. So it's a bit like that. It's like a consumption of your platelets, but it doesn't cause clots because it just consumes your platelets. They get cleared. They don't get activated, remember? So they're just being agglutinated and removed. And so then you're getting a thrombocytopenia, which leads to bleeding. And a consumptive loss of von Willebrand factor as well. So you're unnecessarily binding von Willebrand factor to platelets, but in a passive agglutinating way, which results in both of them just getting cleared. So what you end up getting is an activity to antigen ratio of less than 0.7, but then you also get low platelets and low levels of high molecular weight multimers because they're being consumed by binding too much to the platelet. because
So just for my clarity, they're binding to the platelets, but they're not binding to collagen. So they're just binding everything together in the main bloodstream, and then they get shimmied out. Okay, got you. Yeah.
And so the lab test that we do to pick up this kind is the Ripper that we mentioned at the beginning, which we'll go into later. But it's basically where we do an activity test. We do the standard activity test, the Rickoff, but we use really, really low levels of ristocetin. And normally that shouldn't cause any result, but it does because they're super sensitive, because they're bonkers for platelets, is the crux of it.
Bonkers for platelets.
Okay, so 2B, bonkers for platelets, also autosomal dominant, and is a gain of function mutation, so that the von Willebrand factor is just loving the GP1B receptor on platelets, and they bind together and both get cleared. Okay?
Got it.
You can also get, just to mix it up, a pseudo von Willebrands, which is where the mutation is in the GP1B receptor instead of the von Willebrand factor, but the effect is the same. So the platelet, that's a platelet disorder where the platelet's GP1B receptor is mutated so that it binds von Willebrand factor, which is completely normal this time, but with too high an affinity, and they both get used up in the same way. Does that make sense?
Nice.
Yeah. And that's pseudo von Willebrand's disease. And basically the way in which you can tell the difference between a pseudo von Willebrand's disease and a 2B von Willebrand's disease is by either taking patient's plasma and reference platelets and doing a Ripper, or doing reference plasma or cryoprecipitate and the patient's platelets and doing a Ripper, and then you can compare the two. So you can isolate, is the mutation in the GP1B receptor, or is the mutation in the von Willebrand factor? If it's in the von Willebrand factor that makes the affinity higher, then that's 2B. If the mutation is in the GP1B receptor of platelets, then it's pseudo von Willebrand's, and it's a platelet disorder.
Yeah, got it.
Yeah.
Got it.
Okay, excellent. And then the last one is 2N. N for November. N for no number 8. No number 8. No number 8. Okay. And that's autosomally recessive inheritance. Okay. And so it's presumably rarer because it's recessively inherited. And that is the one where the von Willebrand factor doesn't bind factor 8 very well. And so you get low factor 8. Okay, so that...
And I take it that reduces the half-life of factor 8 and can look a lot like haemophilia.
Yeah, it looks like a mild haemophilia A, exactly. And so that's why you must do tests for von Willebrand's disease when you're diagnosing haemophilia A, because they can look the same. Because they'll both produce a low factor 8. And so the key test that we do here is something called a factor 8 binding study, which again we'll talk about in the lab tests. Okay, but it shows that their von Willebrand's doesn't bind factor 8 very well, and that's how you can tell that it's a von Willebrand problem and not a factor 8 problem. Also, the inheritance pattern will give you a clue. If it's a woman and she looks like she's got mild haemophilia A, you'd be thinking, oh, is she a carrier with just like really unlucky lionization of her, good chromosome, and then just her bad chromosome is being expressed more? Or you would think, oh, could it be a 2N von Willebrand's disease? Cool, hey?
Cool wasn't where I was going. I felt more like, oh my God.
I've lost you. You're like, oh God. Okay, do you want to recap? We're going to stop there, okay? Because I don't want to lose you. But those are that's the classification. We're not going into the lab test now.
Cool.
But do you want to recap that to make sure you've understood it?
Go on, David.
Fine, from the top. From the types.
Just the types. Yeah.
Okay. So type 1 is our quantitative deficiency.
Yeah.
So the antigen levels are low, and therefore not producing clots as we'd hope. And we said, was that less than 30 international units per deciliter?
Yeah. And just to say, sorry, I should have said this already. The lab test is not great. So whenever you do a von Willebrand's screen, you have to repeat it. So you need 2 abnormal tests, okay? Because it can be affected by stress, by DDAVP. If you've just come in and you've walked fast to get to your appointment on time, all of this can affect it. Infection, it's an acute phase response, etc. So we always need 2 abnormal tests and a bleeding history. Don't forget you need a mucocutaneous bleeding history as well. Okay, sorry, carry on. Yes.
And I take it that's a decent period of time apart, those two tests.
I don't think they
months?
specify.
Are we talking months,
actually.
or are we just talking?
They don't
Okay.
specify, but I mean, from my experience of the lab, like, we have to fire up the von Willebrand's disease machine. So that in itself can take a while.
Okay. Fine.
Unless...
I won't derail us. So I'm going to go in kind of the order we said. So type 1 is a quantitative. Type 3 is a quantitative as well, in that there's virtually no less than 1 international unit per deciliter.
Yeah.
Which can be linked with a severe sort of bleeding phenotype.
Yeah.
Then our type 2s, which is a qualitative problem.
Yeah.
1C.
Don't worry about 1C. It's a small fry thing on the side, but yeah.
It's that little Italian village. It's okay, don't worry about it.
Stop it, Ada. You're on my team here.
He's on a roll, Ada. He's on a roll. Don't interrupt him.
Type 2A is absent multimers.
Yeah.
A for absent.
Yeah.
So it's loss of making the big multimers, which we think was likely due to the Adams TS13 being overactive and breaking everything down too quickly.
Yeah. It's like the opposite of TTP.
Opposite of TTP.
Yeah.
Like DIC. Yeah. I've forgotten what M is, but I know B is bonkers for platelets.
M is maintained multimers.
Okay.
So just the opposite of A. It's the same as 2A, but the multimers aren't low on testing.
Okay.
So it's something else wrong with the von Willebrand's factor, whatever that is, that affects its function. Yeah.
B, we have an increased affinity for platelets, and they don't, so they're binding them in the main bloodstream, and therefore being taken out of the system before they're sort of bound to make a platelet plug.
Yeah.
And then N is a binding problem with factor 8.
Yes.
So no
number 8. Very good. See, you got it. You got it. Yeah, very good, guys. Okay, so shall we summarize with 3 golden nuggets? What are our golden nuggets going to be? 1, von Willebrand's disease classically presents with mucocutaneous bleeding. Number 2, especially GI bleeding, by the way. Number 2, it's made in the vascular endothelial cells, which is released all the time as small molecular weight multimers and dimers, but then also has a releasable pool in the vascular endothelium, particularly in the lungs, that's released by DDAVP and is rich in high molecular weight multimers. And it's also made in megakaryocytes, so it's found in platelets. And then 3, there are 3 types of von Willebrand's disease. Essentially, you need an antigen level of less than 30 for type 1. Type 2, you need an activity to antigen ratio of less than 0.7. But usually in reality, it's less than like 0.5, to be completely honest. And type 3, where there's no von Willebrand's factor at all, or less than 1. And I think we'll leave it at that. What do you reckon?
Sounds good.
Okay, good.
Nice.
So we'll see you guys next time, and we're going to tackle the lab test. So I hope you feel well rested for that.
I think she's talking to us.
Yeah,
not to you guys.
Yeah.
Oh yes, and you volunteered yourself homework as well. Perfect, and we'll open with that next time. Great.
Excellent.
All right.
See you later.
Thanks, team.
Bye.
Bye.
Thanks again for listening to Basics to Brilliance Haematology Podcast. If you enjoy our series, please don't forget to like, leave a review, and hit subscribe to never miss an episode. See you next time.